Kristian Madsen, Mike Gibson, coming to you, talking about the advanced DK 3-year plaque volume study, along with looking at revas. Kristian, talk to us a little bit about what you did and what you found.
Well, so basically what we did was we had 900 patients from the three Danish advanced centers, and we made a 3-year follow-up, recorded all adverse events, had them adjudicated by an independent event committee. And then to start with, we assessed how an abnormal FFRCT associated with prognosis and how it related to the calcium scoring. And we published that paper in Radiology. And then obviously the next step would be to quantify the calcium score by looking at the plaque volumes and how the different plaque types were involved in the prognosis of these patients, and also how it related to revascularization. So we had the artificial intelligence-enabled quantitative plaque analysis performed by HeartFlow on all of our patients. So, or most of the patients, 841 to be exact. And then we took a look at it, and what we found was quite interesting, because when you look at FFRCT, it's a computed measure of flow, right? When you look at plaques, they are the true culprit. You can't have an event if you don't have a plaque. And both of these parameters have been associated with cardiovascular events. So the interesting question to me was, is one of these parameters merely a surrogate marker for the other, or do they provide independent information which we could combine to stratify the risk of these patients? So we started off by performing a scatter plot. And what we found was that the two parameters, they weren't correlated at all, which was a
That's,
surprise.
well, that's not surprising to me, at all. I mean, as someone who's studied QCA for 36 years now, the other thing we know is that, use of FFR in the acute setting may not, in fact, was not good at all in predicting, who is going to be at risk for an event. It doesn't tell you how about the complexity of the plaque, or its contents or propensity to rupture. It only tells you about flow. And so, it's not telling you about the future in terms of the future plaque rupture.
No, and you're absolutely correct. And that's the same issue with FFRCT, really, right? Because it's a computed measure of flow, but you need to have, at least the theory is, you need to have some vulnerable plaques that are prone to rupture. But what we found was that the two parameters, they were not correlated. But when we then assessed patients and we said, okay, you have patients that have an abnormal FFRCT, and you associated that with plaque, we found that with increasing amounts of plaque, and that was actually regardless of the type, then the event rates we saw were also increasing. So there seemed to be an interplay between the two parameters, that if you had abnormal FFRCT, then if you had more plaque, you were more prone to have an event. But what was extremely interesting was that if you had a normal FFRCT, it didn't really matter. You could have more plaque, but the event rate just was constantly very low, regardless of the amount of plaque. And this was also confirmed by rock analysis.
Say that one again. If you had a normal FFR, it didn't matter how much plaque you had. Is that right?
Exactly. Then the plaque became less relevant.
Hmm.
However, if you had abnormal FFRCT and you had a low amount of plaque, you
Hmm.
also had a lower risk of future adverse cardiovascular events. So they seem to be correlated in such a manner that if both are present, then you have the highest risk patients. And we don't know exactly the reasons for this, but now today at TCT, the Emerald 2 data was just being presented. And if we look at those data and see how the delta FFRCT value correlates with plaques in terms of predicting future myocardial infarction, then it starts to make sense, right? Because we use what we call the 2 centimeter distal to stenosis FFRCT value. So it's not delta FFRCT, but you cannot really have an abnormal FFRCT interpretation using the 2 centimeter distal to stenosis value unless you have a significant focal drop, which would be the same as the delta FFRCT value. So I think that our data is complementary to the Emerald 2 data, actually.
So this is fascinating, Christian. It's very exciting. Do you see this fitting into the reports? Maybe it's an educational tool that docs get back about their patient, like a 2 by 2 matrix of, here's your risk, incorporating both FFR and plaque morphology, using AI to give you a better estimate of someone's risk.
Yes, I I would say that if we have a patient and we get this information and we can stratify their risk profile, then we will have a group of patients in whom we know we need to be more aggressive, utilizing optimal medical therapy. Like statins, checking up on them. Are they consuming their statins? Make sure that they do. Also ASA, etc. So for that purpose, yeah, it will identify patients in whom we should probably take greater interest in order to try and prevent them from having a future cardiac event.
Now, one question I always ask when we're looking at ROC curves and area under the curve, if you had a prediction by one parameter, say FFR, and you looked at what someone's risk with that, did knowing the plaque volume change that risk assessment? So, how often was there a risk recategorization when you add in plaque, for instance? Do you know
Well,
that?
yeah, well, if you add in plaque, you gain more information.
You
You
gain
don't
more
gain
information.
significantly more information. Actually, it's the other way around. So that if you have a baseline risk variable profile of the patient, and then you add plaque to that, then you gain a significant amount of information. So you can identify patients at higher risk utilizing the plaques compared to baseline risk variables. And if you put flow measures on top of that, then you gain a significant more amount of information. So
Yeah. Well,
surprisingly cool.
sometimes we characterize that mathematically as the net reclassification index, where you look at someone's risk and you reclassify it with each variable that you add. So it sounds like these variables sounds like they help reclassify people's risk, which is very exciting.
Yeah, yeah, they do, but we haven't performed those calculations yet, which you are referring to. I don't
Great.
have the data for that at
Well,
this
that's my
point.
job. That's my job as the interviewer here to ask the tough questions. So,
Of course, of course.
well, thank you so much for joining us, Christian. Very exciting data, and I look forward to seeing what you do with all that information, how we can better predict outcomes. Thanks for joining us.
Well, thank you for having me, and you
All
have
right,
a very nice day.
you too.
Thanks.